Yes.
Dr. Shirley, I have some questions which have, I've been asked to ask you by core participants. So they'll dot around from topic to topic.
Okay.
You referred to a book maintained at Frimley Park which collated information about the patient, their diagnosis, their treatment and so on. I know you left Frimley Park a number of years ago, but do you happen to know if that book still exists or what became of it?
No, I don't.
Then in relation to the patient, Mr. AJ, that we were talking about before lunch, I've been asked to ask whether that patient was part of any trial at the time his treatment was given in December 1984.
No, he wasn't.
And then in relation to Scottish concentrates, I know you said I think you had no awareness of, you don't remember being aware of a Scottish concentrate being one of the products that was administered to that patient. Do you recall whether you received more generally Scottish concentrates on other occasions and whether you used them on other patients?
No, I don't. And I only know that one vial of Scottish concentrate was used in that patient because it's on his blood transfusion records, which I have access to.
So it's not something you've got any independent memory of receiving and using Scottish concentrates?
No.
When you were giving your explanation as to why you and your colleagues concluded that patients being tested for HTLV3 wouldn't be told that they'd be tested, the possible impact on insurance, was that something that you considered later when you were arranging tests for hepatitis C? Did you consider the implications for insurance at that stage? And if not, why not?
No, because I wasn't aware that there were any insurance implications with regard to hepatitis C, although in hindsight, I presume there would have been, but it didn't carry the same stigma that HIV did in the 1980s. So it was a slightly different situation.
Now, your evidence in relation to the first part of the 1980s and your arrangements with Tooting was that when you were ordering products from Tooting, you didn't specify NHS or commercial. Given that your understanding, certainly in the course of 1984, that comparatively commercial concentrates posed a higher risk than NHS concentrates, why didn't you raise that with Tooting?
I probably thought that it wasn't my place to do so. We relied on Tooting to give us what they had available. There was no self-sufficiency in blood products in the UK. And I probably naively, I took the view that what was given to me was what they had, and that they didn't have any choice in what they were supplying.
Now, you also, in your evidence this morning, explained that you were running, again in the first half of the 80s, the haematology department single-handedly, and that contributed to the fact that you wouldn't necessarily be able to attend all conferences or keep us up to date as a haemophilia specialist might do so. Did it cross your mind or the hospital's mind that you could have used perhaps more junior doctors working under you or working in the haematology department to help keep up to date with developments, send them to conferences, send them in your place to the UK HCDO meeting you couldn't attend?
I didn't have any junior staff. One SHO in general medicine was assigned to me part-time to help with the haematology clinics and haematology inpatients, but I didn't have any staff specifically assigned to me, so I couldn't have asked them to go to conferences in my stead.
And then in the course of the 1980s, was there any kind of either formal or informal auditing of associate centres such as yours by UKHCDO or by connected reference centres?
No, I don't think so, and I don't remember anybody coming to audit the setup at Frimley Park Hospital.
Did any of the consultants at the reference centres that you were dealing with, so Royal Free, St Thomas's, Oxford, did they ever actually visit Frimley Park in the 80s?
No, they didn't.
Then, in relation to the batches, which you would have understood by August 1985, one of those batches had led to the infection of the patient that we were discussing before lunch, Mr. AJ. What, if any, steps were taken by you or to your knowledge others to follow up those batches?
I sent Dr. Ritzer a list of the batches of the factor VIII concentrates that I had used in the patient and asked for him to follow these up. And I also later, I think I sent it to the Blood Transfusion Authority, a list of the units of cryoprecipitate I had used on this patient to see if any of those had been contaminated. But I was never given any information as to whether they had identified HIV contamination in any of the products I had used on this patient.
So the units of cryoprecipitate, you contacted Tooting, the concentrates, Dr. Ritzer, and you never received an answer either from the transfusion service or from Oxford as to any particular batch?
I didn't. To this day, I have no idea whether what I gave the patient is what caused his HIV. I've assumed it was, but I've got no proof.
So just in relation to that, you've no reason to think it's anything other than his treatment at Frimley Park that gave rise to the HTLV3, have you? But you don't know which.
No, I haven't. I asked all the relevant lifestyle questions and the replies were negative. So the only way I can think of that he got his HIV was through the blood products that I gave him. But as I've said, I've got no firm proof about that. Because
you don't know what happened to any tracing exercise?
Yes, that's right.
You said in your evidence before lunch that December 1984 and the AIDS advisory document was the first time you can remember guidance being given on product use. Would you accept that the June 1983 letter that we looked at, which recommended directors continuing with a policy of DDAVP or reserving NHS products for certain categories of patients, did you understand that to be some form of guidance on product use from UKHCDO?
Yeah, yes, it was some form of guidance, and that may be why I used NHS product in Mr. AJ. It may have been as a result of that I used NHS product for him, because I knew that he hadn't had any product for a very long time.
Now, you referred at one point in your evidence to if you're giving emergency treatment, that may impact upon the extent to which you would provide full and detailed information to patients about the risks of treatment. And you referred also to bleeds that might lead to disability. Would you accept, first of all, that the kind of bleed that Mr. AJ, the patient, was experiencing, that wasn't an emergency or life-threatening situation, was it?
It wasn't life-threatening, but it was an emergency in as much as if he didn't receive prompt treatment, it could have led to permanent disability.
But there was nothing about the circumstances in which his treatment was required that would have precluded a conversation about risks and giving the patient a choice?
No, there wasn't.
And to what extent were, or what proportion of bleeds that you customarily treated in the first half of the 80s were life-threatening? Was that something that you ever came across?
No, it wasn't.
You referred to the Haemophilia Centre Director's Handbook in the course of your evidence, and I think there's been a request for clarification of what that is, and I'm going to ask you to look at one of the documents you exhibited to your witness statement and see whether that's what you were referring to. Shomik, could we have WITN 3901-020? And if we go to the next page, please. I'm looking, I'm not sure what page it is, but I'm looking, Shomik, for a page.
I think you need to go back for the cover.
Yeah. There should be under that reference something that looks like this.
Otherwise, I've got it here and I can put it up. If you go back again, you should have the cover.
That's it. So, Haemophilia Centre Handbook, notes for doctors and nurses involved in the care of patients with congenital coagulation disorders, compiled by Jennifer Vogt, Colin Madgwick and Catherine Dormandy, published by Immuno Limited, and we can see your name handwritten at the top. Is this the book that you were referring to, the handbook you were referring to?
Yes, it is. And that's what I used from the time I became a consultant. Well, in fact, I used it all through my practice because the actual management of the patients didn't significantly change. It was the products that changed, and the other thing that changed was the advent of using DDAVP. But all the other information in the handbook was still extant at the time that I retired.
Do you have a complete copy of the handbook, Dr.
Yes,
Shirley?
I do.
In that case, we may ask you to provide it to us. But you had it when you started as a consultant in 1980.
Yes.
Do you know when it was published? We see the reference to Catherine Dormandy, who sadly died died by then.
No, I mean, I can look in it now and see if it's got a published date.
Well, I think perhaps we can. Yeah, if you have it to hand, then by all means.
I do. Yeah. First published by Immuno in 1980.
Okay, thank you. And so, as you say, it wouldn't have contained necessarily information about, or it wouldn't have contained information about products that weren't necessarily in general use at the time. It also wouldn't contain information that was up to date about developing knowledge of risks, would it?
It wouldn't have had it. It didn't have information about developing knowledge of risk. It has a list of NHS therapeutic materials and commercial concentrates, and contact numbers for those organisations.
Okay, thank you. Last question, Dr. Shirley. I asked you before lunch about the delay in communicating the test result to Mr. AJ.
Yes.
Did you understand at that time that HTLV3 could be passed on through sexual transmission?
I certainly did by the time I saw him in October, because I gave him relevant information about it. I can't say whether I probably knew about it in August, but I can't say definitely that I did.
Sorry, as I said last question, I'm handed some further questions, so if you would just give me a moment, please, Dr. Shirley.
I mean, the other thing was that if I did know about it, the evidence was that there was a very low risk for sexual partners. There were very few that had been identified as having caught HIV from their sexual partners. Outside of the homosexual population, in the heterosexual population, there was very little evidence that there was a high risk.
And do you know what your sources of understanding were by summer or autumn of 1985 about the risks of heterosexual sexual transmission? Would it have been UKHCDO, or would you have had other sources?
No, it would have been information that I had received through other sources, probably from the consultant dealing with HIV at the hospital.
And then, sorry, one additional question, Dr. Shirley. When communicating the HIV diagnosis to your patient, what safety advice did you give, as far as you can recall, if any, about reducing risks of transmission to others?
I certainly talked about using a condom. I can't remember what else, but I have actually noted that in the patient's notes. And I gave them the booklet, the DHSS booklet on safer sex.
So those are the additional questions I'm proposing to ask. Before I ask Dr. Shirley if she has anything to add, so do you have further questions?
Yes, I do. I'm just, in the light of your answers about sexual transmission, I'm just looking at some of my own notes, because whatever the consultant in HIV knew, my understanding was that it was as early as 1981/82 that the CDC became aware that there had been instances of sexual transmission, including marital sexual transmission between a man and a woman. So that's just what surprised me, just so that you know why I haven't. I'm not going to ask you any questions about that, because you've told us what you were told by someone who knew a bit more perhaps than you did. At least that's what you thought. Can I ask you this? In the early 80s, I imagine, but you can tell me if I'm right or wrong, that you, like many people, got their news from newspapers. Am I right?
I probably more often got it from the radio because, to be honest, being a full-time haematology consultant and having a young family, I didn't have much time for reading newspapers. So it was probably from the radio.
And
radio or television.
It's not supposed to be an indelicate question,
No.
but you were married, were you?
Yes.
And did your husband take a paper?
I can't remember whether we took a paper. I think he probably took a paper when he went up to London to work, and he would have brought the sort of Evening Standard home with him.
Yes.
But to be honest, by the time I'd put the children to bed and cook the supper, I didn't have much time for anything else.
So it wasn't from that source, at any rate, that you became aware, as you've told us you were aware at an early stage, that somehow, for some reason, NHS concentrates were safer than commercial concentrates. Can you tell us why you thought that, do you think?
Really, because at the meetings of the UK Haemophilia Centre Directors Organisation, it was generally felt that UK concentrates were safer because they were from volunteer donors, as opposed to the commercial concentrates, which were made from blood donated by paid donors.
Now, on the face of it, just looking at that information as it stands, the fact that someone is paid for a donation compared to whether someone gives it free has nothing on the face of it directly to say about the safety of the blood which is donated. So what did you understand to lie behind the question of the benefits of being voluntary rather than paid?
Because it was thought that in the US in particularly, a lot of the paid donors were homeless and IV drug abusers, and therefore there was a greater risk of transmitting viruses from pools made from that type of donor.
So the safety was a matter of virus transmission?
Yes.
And it was more likely, because of the source of the raw material, that the NHS concentrate you thought would be safer than
Yes.
the US concentrate from dubious sources.
That's correct.
And the question about so that would make it safer, I suppose, and did you saw it this way because of the risk of hepatitis.
That's correct.
At the time, you thought that hepatitis was hepatitis either generally or hepatitis B. You didn't know directly at that stage about non-A, non-B when you started at Frimley Park.
I certainly knew about non-A, non-B by 1985, and I can't say how soon before that I knew about it.
Yes, but when you went to Frimley Park, I think you told us that you already knew that, or felt, that NHS concentrate was safer.
Yes.
And did that that resulted plainly in others in the UK HCDO and others in the field of looking after those suffering from haemophilia to prefer, where they could, to use NHS concentrate?
I think generally we would have preferred it if the UK had been self-sufficient in the production of factor concentrates because we felt they were safer.
And this would be safety not just in some minor aspect, because safety enough to prefer one product over another if you had the choice.
Sorry, I didn't understand the question.
Sorry. Well, what you've just described about self-sufficiency is really a question of what was available, isn't it?
Yes.
And you're saying, well, if you had unlimited availability of NHS and unlimited availability of commercial concentrate, you would always have chosen NHS concentrate by preference.
That's correct.
That suggests that you thought that the risk of hepatitis was sufficient to make a real difference.
Yes, I thought that the risk of viral contamination, with regard to hepatitis B, most patients were infected with hepatitis B, whether it was NHS concentrate or commercial concentrate. But as we went into the 1980s, it was felt that there was less risk of contamination with other viruses in NHS concentrate than in commercial concentrate.
And sufficient, as you've told us, to make a difference in what you would actually use.
Yes.
Or choose to use, if you had the choice.
Yes. Yes.
Just looking at the
Frimley, I often didn't have the choice.
No, you've said that very clearly. You relied upon what was available at Tooting.
Yes.
Can I just ask you, in relation to that, did you ever have visitors coming to the area who happened to be haemophiliacs who required product to manage their condition?
We did very occasionally have a visitor who wasn't on home treatment and had a bleed and needed to have some treatment.
We've been told in the inquiry that a number of people were warned by their regular doctor that if they needed to get any treatment while they were away from home on holiday, they should always make sure that they asked for, and it would be whatever concentrate they happened to be on. So if they were from Scotland, they might be advised, whatever you do, don't have any English product, have some Scottish product. We've heard examples of that. Did you have anything like that said to you? Do you remember?
I don't remember that happening.
If it had been, do you think you'd have been able to go to Tooting and say, look, I've got someone here who's been told he really ought to be on Scottish concentrate or armour, whatever it may be. Can you get me some? Do you think you could have done that?
Yes, I think so. Whether Tooting would have been able to access it, I don't know, but there's no reason why I couldn't have gone to Tooting and said, could they get this particular product?
So you wouldn't have felt it was a lost cause at the start to do that?
No. I think I could have done that.
So your sense was that in particular cases they might have been able to get hold of the product you wanted?
Yes, I think one of the ways they might have been able to get hold of it is to ring round some of the haemophilia centres in London to find out if they had got that product, because some of them would have got their product from other transfusion centres such as Colindale, and so if Tooting didn't have something, they might have been able to access it from somewhere else.
You're not far away, I think, from the centre at Trelaws.
No, that's right. I mean, I don't know whether they. I don't know what arrangements they had for having product available there. I mean, obviously they must have had some way of storing blood product, but I don't know anything about their facilities.
No, the reason I mentioned that, it's been the recollection of a couple of the witnesses who we have evidence from, who went to school at Trelaws, that Dr. Aaron Stam sometimes spoke about what was in the fridge and said, well, the best is the Scottish and the next best is, and so on. So plainly, if that's right, he had a choice of what he might be able to offer the lads who were at his school or under his care. And so it suggests that there was some availability, at any rate, in that location, albeit maybe supplied from Oxford, of those particular products. So it rather backs up what you're saying, that perhaps Tooting could have rung round and obtained what was necessary. Can I ask something slightly different? You were engaged in the study in respect of HY.
Yes.
You did it, I suspect, because you thought it would be useful for such a study to be undertaken.
That's correct. I mean, over my time as a consultant, there were a few studies, generally in haematology, not just in haemophilia patients, that I entered patients into because I thought it would be useful to gain the knowledge, and I felt in a way it was my duty, if I had suitable patients, to enter them into trials.
What did you think might be the useful outcome from the 8Y study?
That the heat treatment prevented transmission of viruses in the 8Y product.
And you put that in the plural, viruses, so it's not just a question of HTLV3, but a question of other viruses too.
Yes, I mean, I was particularly thinking of hepatitis viruses and HIV with respect to the heat treatment of the 8Y product. Was
it, do you think, more the hepatitis viruses? Because it was, I think, generally regarded that one way or the other, the commercial products and the NHS too had sorted the problem there had been with HIV or HTLV3. Do you think it may have been more the hepatitis than the HIV, or not?
I think it was more the hepatitis, because it was the hepatitis side of things that I was asked to follow up with, taking regular blood samples for liver function tests from the patients who were part of the HY trial.
So at that stage, at any rate, in 1985, you saw it as a real benefit to the medical fraternity and of their patients to be able to eliminate, if one possibly could, or significantly reduce the amount of hepatitis non-A, non-B, which is being transmitted by blood and blood products.
Yes.
Now, when you were asked a moment or two ago after lunch by Ms. Richards why it was that you think you used NHS product on Mr. AJ, you said you thought that might have been because of the fairly vague guidelines which the UK HCDO had promulgated back in June 1983, preferring NHS concentrate.
Yes.
Or cryoprecipitate.
Yes.
But that itself suggests that you might have had, or felt that you had a choice of what product to use. It wasn't simply what came off the shelf at Tooting.
I think what was recommended at that time was that patients who were receiving concentrates for the first time, or who had previously received concentrates early on, like the beginning of the 1970s, and hadn't had any since, that it was better to use NHS products in those patients. Whereas patients who had received a lot of commercial products in the past, if you had to choose between using commercial product in that sort of patient or NHS product, and then you had another patient who had received very little product, then you would be using the NHS product in the very little treated patient and the commercial product in the patients who'd received a lot of commercial product in the past.
I think my question was really more about your relationship with the supplies that you got from Tooting, so far as supplies were concerned.
Yeah. Yes.
And some of your evidence given earlier might have suggested that you took what you got because you had no alternative. Tooting were there supplying you with what may be commercial concentrate, might have been NHS concentrate, but you took what you got. The answer that I was asking you about was one where you seemed to be suggesting that you had made a deliberate choice to use NHS concentrate. In other words, it wasn't just a question of what you've been given. It's a question that you could make a choice between NHS at any rate and commercial concentrate at that time. That's what my question was about.
Yeah, it's difficult to know, looking back, whether we would have had NHS concentrate and commercial concentrate in the blood bank at Frimley Park Hospital at the same time, or whether we were in a situation where we could say by the mid-1980s, whether we could say to Tooting, we've got a patient here that hasn't had very much factor VIII in the past, and can you please send NHS product for this patient? I can't say definitely whether that was the situation or not, but obviously I used NHS concentrate in this particular patient. I can't say whether it was because we specifically requested NHS concentrate or whether at that time Tooting was able to provide us with NHS concentrate rather than commercial concentrate.
Now, from the answers you've given me earlier, the advantage of NHS over commercial was the lower risk of a virus being in the NHS concentrate. And it must follow, I suppose, that there is a greater risk, the greater number of batches one uses of a particular concentrate.
Yes.
So if you are having dedicated supplies for somebody who might be at risk if they get one of the batches which is contaminated, it might be sensible, might it, to see that they can always have the same batch. It's something we've heard in this inquiry as being batch dedication.
Yes, it would be sensible.
And in this particular case, in the case of Mr. A.J., do I understand that he had a number of transfusions, infusions, from different batches?
He did. He had a number of transfusions on a number of different days, and I suspect that happened because we were asking on a daily basis for Tooting to send us factor VIII, and it was what they sent us.
So this wasn't a question you were saying, well, he's got a bleed in the iliopsoas muscle. He will need quite a lot of treatment. Cryoprecipitate isn't working well enough. Needs some concentrate. Let's get enough in to cover him while he's here. That wasn't the way it worked.
Well, we didn't know how much he was going to use because he was being assessed on a daily basis as to how his symptoms were progressing and whether he needed any more concentrate. And then I felt, and it was recommended, that for a psoas bleed for rehabilitation that you should cover the first few physiotherapy sessions with factor VIII until you were quite certain that he wasn't going to bleed again as a result of the physiotherapy. So at the beginning, I would not have known how much factor VIII he was likely to use.
And you wouldn't have been able to estimate that, do you think?
No, I mean, what happened, the cryoprecipitate didn't give him a high enough factor VIII level in the blood. So I then gave him a dose of factor VIII, which raised the level quite substantially. I think I was giving him 800 units. And then I reduced that to 500 units, and that was giving an adequate response. So it was dose response related, and it would have been difficult to ascertain how much overall the patient was likely to need.
Now, let me change to something else. When do you think you were first aware that a UK haemophiliac, it's Scotland, England, Northern Ireland, Wales, UK haemophiliac, had died of AIDS?
I certainly wouldn't have known before 1983. So I think it would have been 1983 or 1984, round about that time.
We heard the day before yesterday from Dr. Bevan when he was trying to tell us what happened when. He had a number of very clear pictures which he painted vividly for us of certain events which had happened which made him remember these sort of things which stand out in memory. And you know the sort of thing that may happen if you're talking to your children about incidents in their childhood. You'll remember some of the events which happened long ago. That's the way we work, isn't it?
Yeah.
Is there any particular picture which stands out in your mind in 1982, 83, 84 about the particular risks of treatment of treatment generally of those who had the condition of haemophilia?
No, I can't think of anything that really stood out in my mind until my treatment of this particular patient at the end of 1984. You have to remember that I was also looking after hematological malignancies, leukemias, lymphomas, maternity cases, surgical bleeding cases. Now, I remember vividly some of those from an earlier time, but I don't remember anything in particular about haemophilia, HIV, and really it's this patient that stands out in my mind as the time that I really became aware of the issues regarding HIV and haemophilia patients.
Now, the last thing I want to ask you about is this. You told us earlier how you would see the patients, often mild to moderate, who suffered from haemophilia, but others too, I suppose, when you were meeting them at outpatient appointments, fairly routine outpatient appointments. You also mentioned that people who were in home treatment would have picked up their supplies from the blood bank. So was that an occasion, do you think, when they were picking up their supplies from the blood bank, that you might have seen them? Or did they just come in, pick up their supplies and go away without speaking to you?
Generally, they came to the blood bank and picked up their supplies and went away. I occasionally saw them if I happened to be passing, and then a lot of the others had their supplies sent to them direct at home, so I wouldn't have had any interaction with those patients.
Did you see them at all?
Except at routine outpatient appointments.
And would you know at the outpatient appointment whether they had an interim visit to the reference centre, such as St Thomas's or Oxford, wherever they were primarily receiving their treatment?
Yeah, well, I would normally ask when they had last attended their haemophilia reference centre.
The reason I'm asking about this is you mentioned about the fact that you thought that haemophiliacs generally were aware of the risks that they might get hepatitis from treatment. They wouldn't necessarily have been quite so aware of the risk that they might get an infection which could lead to AIDS from their treatment. In 1983, when you first became alerted to it by the various materials that Miss Richards took you to. Did you ever, do you remember, saying to any of them during their your outpatient attendance, I do have to tell you that there is now, I should warn you, there is now a risk in your going on having these blood products that you might be taking something which could lead to AIDS?
No, I don't remember doing that.
Do you think you did?
I don't think so. I don't think so, because I would have thought that their main centre would do it. If you're... My recollection is that with those sorts of conversations, you normally would have somebody like a haemophilia nurse to be able to take the patient and deal with their questions and everything in a fuller way. I didn't have that sort of facility available, and if you're going to tell somebody something like that, you really need some sort of backup with information, and for them to be able to ask more questions and to come back. And I was on my own. I didn't have any sort of nursing backup, and I just didn't feel that I had the capacity to be able to do that.
What information did you have about what the reference centre was actually telling or not telling the patient?
I didn't have any information that I can recollect.
Well, that's all that I have to ask. Thank you very much.
So there is just one further matter I wanted to ask Dr. Shirley about in light of the questions and answers. Could we have up on screen, please, BART 302269? And I should say this is a document that Dr. Shirley herself refers to in her witness statement. So we can see these are the minutes of the Haemophilia Centre Directors meeting from the autumn of 1984, 27th of September 1984. We can see the location was Cardiff, and you're not down as attending. Is that because it would have been too far away for you to attend and get back the same day?
Yeah, that's correct.
But you would have received the minutes, although we don't know when they were sent out.
Yes, yes.
Could we go to page 12, please? And look at the bottom of the page under the heading AIDS. It refers to Dr. Krask referring directors to a report on the current situation regarding AIDS, outlining progress to date within the UK Haemophilia Centre Director study and reviewing the literature. Directors were asked to give special attention to the work on HTLV3, and then he refers to the AIDS survey. And then he says this, and this is the sentence you've picked out in your witness statement, Dr. Shirley. So far, no patients who have only received NHS concentrates had shown HTLV3 positive results. And then he goes on to say HTLV3 testing had only been available since August 1984, and he would only give directors reports on the results when he was sure of the information. Now, in terms of that sentence, or part of a sentence, so far no patients who've only received NHS concentrates had shown HTLV3 plus results. You point to it in your statement, I think, please correct me if I've misunderstood, as an indication that reinforcing your view that NHS concentrates were safer than commercial concentrates. Was that what you were trying to convey in your statement?
Yes.
Would you accept that this is not, doesn't exactly read, or it might be thought it doesn't exactly read, as a ringing endorsement of the safety of NHS concentrates? It's saying not we're not expecting there to be any positive results. Rather, it's saying so far no patients who've only received NHS concentrates have shown HTLV3 plus results, but it goes on to explain testing's only been available since the previous month.
Yes, but it would suggest that it would be better to give patients NHS concentrates than commercial concentrates.
But it wouldn't provide, would it, a basis for being confident that NHS concentrates themselves were free of risk?
No, it wouldn't. But from my point of view, it would have been reassuring that there was a much lower risk with UK concentrates.
Okay, thank you. That was the document I wanted to ask you about, as you'd referred to it in your statement. Dr. Shirley, do you have anything further that you want to add?
No, I don't think so, thank you.
Sir.
Well, Dr. Shirley, can I thank you very much for giving evidence. It's always difficult, I think, particularly when you had so many other things to think about at the time, not only clinical commitments, but your young family as well, to remember back. What you've been very helpful in doing is painting us, nonetheless, a picture of what it was like to be a director of a very small, that is, by comparison to some of the other centres we've heard, very small centre and associate centre treating those who had haemophilia in the period between 1980 and, in particular, the evidence you've given, 1986. Can I thank you for the insights you've given us into what it was like and the way in which your information and product choice was affected by others in the field, although you did have, as you accept, some responsibility yourself. It's been very valuable to listen to that. And can I thank you for that, and you're attempting as best you can to remember back and to ask what may have seemed to you at times to be rather searching and probing questions. But thank you.
Thank you. Well, I'm glad I've been of help.
You have.
So that's the evidence for today, and tomorrow we have Professor Collins.
Yes. So tomorrow at 10 o'clock, Professor Collins.
Yes.
Thank you very much.